together. It was outstanding. I'm going to welcome our validators and champions. So we thought it was really important that you hear from people, leaders from around the world that can really tell us why they commit energy and resources to the work that is done in the Global Alliance. So you're going to hear a little series of rapid thoughts from a few different individuals. I'm going to call them up one by one to share their 3 minutes, along with a tweetable slide quote that you'll see behind them. We're not putting on a Broadway show, though I think we could do the kicks here. So, all right, with this, I'm going to start off with Bartha Knoppers, who's from McGill University in Canada, has been a member of our steering committee and is co-chair of the Regulatory and Ethics Work Group. Bartha.
The right to benefit from science, the advances in science, the right of everyone to benefit from progress made in the fields we work in. What does it mean? I've never heard of this right. Aren't there other rights that already exist that help? The right to protection of health, the right to privacy, the right to non-discrimination, the right of the freedom of expression. This right is a right that belongs to everyone. It's a human right. And being a human right that is legally recognized means that 165 countries have signed and ratified. Because it's a legal human right, it's actionable. That means you can activate this right as individuals, as groups, as populations. It means you can hold your government accountable. What have they done to respect this right? How can they ensure that this right becomes real in healthcare? It also means that it can be used by individuals and groups to hold governments accountable. So it's actionable and accountable, and it's a right that no one has really used up to now in both research and the clinic. It is translational. It crosses the lifespan from birth to death. It crosses from research to the clinic as well. And it is unique because it is universal. It supersedes, as a human right, all jurisdictions, all languages, all countries, and all legal systems. And in that sense, being both actionable, accountable, translational, and universal, it is a right that we need to use. It is a right that the GA4GH will start, hopefully, a movement to get countries to wake up and realize this right.
Thank you, Bartha. Next, we have Katherine North from Australian Genomics. She's vice chair of the steering committee and has now leading the partner engagement as well as a driver project champion for the Australian Genomics program. Katherine.
As we've already heard this morning, global data sharing is really essential for us to harness the value of genomics, and no one country can do this alone. We all know that we need to share data from millions and millions of patients to better be able to diagnose and to target therapies for the one individual. 5 years ago, genomic sequencing was still the remit of the research environment. And as Ewan has told us this morning, within 5 years' time, we expect at least 80% of the genomes to be generated within a healthcare setting. I'm a paediatrician and geneticist and neurologist by background, but looking at our healthcare system and the complexity and the volume and the responsibility associated with this huge disruptive technology that we're dealing with really makes me question whether our healthcare system is ready and ready for that change. And it's our responsibility to make that happen. I think an incredibly important part of our future at the Global Alliance for Genomics and Health is the partnerships that we have developed and continue to develop between countries that are implementing genomics into clinical practice. We're sharing data. We're learning how to share our data across borders, clinical and genomic data in a responsible way. But we're also sharing our experiences in terms of what works and, most importantly, what doesn't, so that we can all learn from each other, share our expertise and accelerate this progress. And what is the best thing about this is we're really establishing an international community that's got a common focus in delivering the very best in healthcare. I think another important part of bringing countries together is that together we can engage with governments, because the natural progress of this has to be providing an equity of access to all people. As Barbara has said, it's their right to benefit from these great advances in health and medical research. And we need to ensure the sustainability of what we're doing within a healthcare system. Our ultimate goal is to transform healthcare. Currently, we wait for a disease to happen and then treat it at a high cost and a low effectiveness. But really, our focus needs to turn much more to prevention and early intervention. And I really believe that the Global Alliance is bringing together a world of knowledge for the benefit of an individual.
Thank you, Katherine. Next up, Sumit Jamar from Global Genes Corporation in India.
Thanks, Heidi. Now, I'm going to take you to the other side of the world, which is India. And India being the largest democracy, I think we need some participation from the audience. So may I request everyone to stand up, please? Okay, what we're going to do now is you're going to repeat after me and clap the phrase, okay? So we're going to say this tweet together. Diverse population. Clap. Genomic data. Clap. Is critical. Clap. To realize. Clap. The promise. Clap. Of precision medicine. For all. GA4GH 2017. That's a mouthful, so let's see who can say it once. GA4GH 2017. And then the bigger one is GGC Democratizing Healthcare. GGC Democratizing Healthcare. Great, a big clap now. And thank you. Now we have some energy in the room. So look, what does Global Gene Corp do? We were founded on a simple premise that we have to solve the lack of genomic data diversity. And where 60% of the world's population represent less than 5% of genomic data. I come from a country of 1.3 billion people, which is 20% of the world's population. We are less than 1% of genomic data and representation. And the thing is, it's a really tough problem to solve. And we can only solve it in collaboration with everyone in this room and with people outside this room who are interested in genomics. And that's why what GA4GH does in terms of bringing us all together is so critical to us. And that's why we are delighted to be a part of it. When I talk about acquiring data, as many of you know, it starts with the first process, which is around ethics. Do we have the right ethical consent to acquire this data? Because we're dealing with the most sensitive and private data for an individual. Second, how do we acquire this data? When you're in rural India and you take a blood sample, how does it get within the parameters to our lab within 24 hours? We have had to innovate around that. The third is, there are no electronic health records in most cases. How do you transform that? Is that a challenge or is that an opportunity? And what we have done is, we have said, well, people may not have electronic health records, but they do have a phone. There are 450 million people who have internet connections. 80% of them are mobile. And we're using that to create that. So rather than spending money on integrating electronic health records, which has its challenges, we've had to create it. But that's where the whole GA4GH and the alliance that we have with our friends here is so important, because it helps us accelerate that process and move that faster. So again, thank you to GA4GH. Thank you to all of you. Thank you for Welcome Genome Campus for having us there in Hingston. Thank you for the Singapore government as well as Indian government entities who are supporting us in this endeavor, because we can only succeed together. The thought I wanted to leave with you today was, we need your help as we acquire this data to make sense of it, because ultimately we have to change and impact the life of every single human being. That's what precision medicine for all means. On a personal note, what really drives me, I have a 3-year-old son, and when he grows up, I want him to be part of this and included in the genomic revolution. Thank you so much for your time. I'll hand it back.
Thank you. Next up, Isia Lopez-Sendes from the University of Campinas in Brazil.
Good morning. I will start by telling you about a successful story that was fundamentally changed by the interaction with the Global Alliance for Genomics in Health. 3.5 years ago, when we were finalizing the plans for the launching of the Brazilian Initiative on Precision Medicine, which I represent here today, data sharing was not in our top priorities. However, this was changed after I attended the first plenary meeting that was held at the Wellcome Trust. This was so that when we finally launched the BIPMED in November of 2015, the first product we made it available to the public was a genomic database that was publicly available and that was generated from data from Brazilian individuals. This was the first publicly genomic database that was made it available in Latin America. And this has changed fundamentally the way we see data sharing in Brazil and in other Latin American countries. So that now, as we move forward together with the Global Alliance into this new phase, we also want to connect additional partners in Brazil and in other countries to engage additional national initiatives that are going on in Latin America, because we know that the genetic variability that's present in this part of the world is still very much unexplored. Based on data we have generated over the past 2 years, and I'm a data scientist, I always have to mention a little bit about data, we have found that to at least 25% of rare variants that are described in normal health individuals in Brazil by the means of whole exome sequencing have never been deposited before. So it is clear that this has an enormous impact in the way we interpret genetic variants in the context of disease. So if we want to implement and to make the revolution of genomic medicine reach different corners of the world, including Latin America, we'll have to better explore, record, and share genetic variability that is disclosed into this population. And finally, we believe that we'll only be able to fully appreciate the genomic diversity of the human race by including these oftenly underrepresented and underprivileged populations in the large genomic studies that are going on currently. Thank you.
Thank you. Next up is Nicky Mulder from University of Capetown in South Africa.
Africa is part of the genomic revolution. Its unique genetic diversity is key to understanding diseases worldwide. But unfortunately, Africa has been lagging behind in terms of infrastructure and resources to be able to fully exploit genomic data to date and to translate this to the bedside. So there's a number of new initiatives. The Human Heredity and Health in Africa, or H3 Africa initiative, funded by the NIH and the Wellcome Trust, is a big initiative that's now 5 years old. It's a consortium of over 25 countries, 27 countries, over 500 investigators around the continent. And these investigators are looking at data for over 85,000 participants, looking at 12 different diseases, collecting genomic and rich phenotype data. Now, this data needs to be harmonized. We've got H3 Bionet, a Pan-African Bioinformatics Network, which is helping to harmonize this data to make sure this data is deposited in public repositories under access control. But there are many challenges associated with secondary use of data because of the country laws, because of ethics review boards. So the consortium is working very hard to address these issues. Now, the amount of African data in public repositories is very, very low. It's very underrepresented, and this huge data set that H3 Africa is generating has potential to contribute enormously to this. And in order to do this, we really need to draw on the standards, especially in our resource-limited settings, to draw on the standards that GA4GH is developing. We can use the metadata standards, we can use the standards that they're generating for exchange of data, for the tools and the APIs for the analysis and the interpretation of these variants. We have, in a very small data set, just found more than 7 million novel variants that I've only found so far in these African populations. And so we need to be working with the GA4GH. We have been working with him over the years. And I think the most important is the regulatory framework that GA4GH is developing to enable responsible sharing of this data while still protecting the privacy and the security of all the participants, which is quite sensitive at the moment in many African populations. So I think that studying African populations, as has been mentioned by my colleagues, is really important because of the genetic diversity. It's not just for Africa, it's for all those people of African descent around the world. And I think the data has got can provide key insights into diseases for all of these populations of African ancestry.
Thank you, Nicky. Next up is Mark LePage from Genome Canada.
Thank you, Heidi. Bonjour, mesdames et messieurs. Genome Canada has been fortunate and honored to be with this enterprise since the early days, going to the meeting of 7 or 8, however many there were, with Tom and Bertha and many others. But we have 3 minutes, 3 things that I'd like to impart this morning. On research, in a few months, we'll be announcing a selection of 15 to 20 large-scale personalized health research projects. Many of you are collaborators, many of you have been reviewers, and we thank you for that. This will be a big enterprise for Canada, perhaps $200 million, which in Canada is a big effort in this field. Lots of data, lots of consents, lots of international collaborations. We need the Global Alliance to make this be as good as it possibly can. And a few months after that, I think in the spring, we hope to launch a clinical initiative to link the whole country and our 13 different healthcare systems that we have, our 10 provinces and our territories, in a clinical implementation project in personalized medicine, personalized health, backed by a clinical cohort of about 30,000 to start. And there again, we'll have to struggle across all jurisdictions, and we need to connect to you, to the international community for clinical relevance. And again, data, standards, consents, we have to work through all of that. And we've been very fortunate to have some of the Global Alliance thought leaders with us in the design of this thing from the ground up. So we hope to roll into the future that the Global Alliance is building for all of us. So that's on the clinical side. And then finally on structure, just a few days ago, I was happy to tell Peter that we're renewing our funding for the organization so that he can continue to build this mega multinational that spans all over the world. We know that we have a ton, it's remarkable the volunteer work that we have from the community, but to make that work and align, we need some structure to guide us and set up priorities. So research, clinical, structure, go Global Alliance, go, Canada's all in. Thank you very much.
Thank you, Mark. Next up, Makoto Sumatsu from the Agency for Medical Research and Development in Japan.
Thank you very much. I'm organizing the newborn funding agency, which was born 2.5 years ago. And in order to facilitate the data sharing, I believe there are 2 very critical enemies for the data sharing. The one is, at least in Japan, that there are many Darth Vader type professors who try to use a force to collect all the data and without acknowledging the all other people to publish something. That is terrible. And another one is biological behavior of the human beings or researchers, and which try to hide his or her own data. And because of this, the AMED, our agency, decided to say something as follows. That is, share the data, otherwise cut the budget. So, and as a result of this, at least in Japan within recent 2 years, I'm very happy to see the network among the different hospitals, which include the core regional hospital and the university hospitals. And the total number is about 400 right now. And the program name is IRAD, Initiative on Rare and Undiagnosed Diseases. And from this year, we would like to expand this program into the IRAD Beyond. We have a very important 3 beyond. Beyond diagnosis, we need therapies. And beyond genotyping, we need a deep phenotyping in this case. And finally, and most importantly, we need beyond borders in order to share the data among the different countries. So finally, I would like to cite the very important English poem to understand how important is data sharing. That is, no man is island, entire of itself. Every man is a piece of continent, a part of the main. Any man's death diminishes me because I'm involved in mankind, and therefore never send to know for whom the bell tolls. It tolls for thee. Thank you very much.
Thank you, Mikado. And next we have David Glazer from Verily Life Sciences. David's been on our steering committee and is co-chair of the Cloud work stream, as well as a champion for the All of Us program. David.
So there's a lot of waiting for this to kick in. I'm sure it will shortly. There we go. There's a lot of different languages represented here. I decided I'd speak in a different language, the language of equations. So I have subtitled the morning's message into a concise form, but maybe a slightly cryptic form. And the key to decoding these equations is to recognize that it begins and ends with people. There's people at the top, people at the bottom. Let me talk you through it. The point that we're talking about here, the point of sharing, is that when we are pooling information from a dozen different driver projects, from hundreds of countries, from thousands of healthcare institutions, from 7 billion individuals, we are getting information from each of those people, but if we treat each of them as an island, we will just end up with 7 billion different pieces of information. What standards and policy can do is allow us to actually say all of that information we're gathering can actually act as one large virtual data set that will have benefit. Well, the good news is that once we have something that acts as a large cohort, and we are getting data from each of them, we're now in the world of big data. And the world of big data is a world that the planet is getting increasingly good at. It's moving into a sweet spot of how do we take big data and analyze it. And that's the world of data science, the world that's represented on stage, represented in the room. So once we succeed with standards and policies in taking the data from the 7 billion individuals aggregated over time into a world of big data, data science will allow us, with appropriate tools, to find the knowledge, find the insights in that. And then, of course, when we take that knowledge and apply it back to each individual person times 7 billion, that's where it has impact. That's where we take the learnings from each of us, aggregated into knowledge about all of us, and turn it into health. And that, to me, is the mathematical summary of why we're all here. And the point of the work on the technical work streams is to make all of those pluses and multiplies and equals actually work, to make it actually compute, that we can start with 7 billion people and end up with 7 billion healthier people. Thank you.
Thank you, David. And last up, we have Kim Boycott from Children's Hospital of Eastern Ontario in Canada, and she is a driver project champion for the Matchmaker Exchange.
There are more than 7,000 rare diseases that affect hundreds of millions of people worldwide. The cause of at least a third of these are unknown, and what this results in for patients is something we refer to as a diagnostic odyssey. And this is a lengthy, costly, and ultimately futile for these patients series of investigations. The absence of diagnostic clarity for their patients and their families adversely impacts their care. It leads to a rudimentary state of knowledge with regard to natural history, genotype-phenotype correlation, best practices, and familial recurrence risks. From a personal perspective, working as a clinical geneticist, seeing children every day with rare diseases, finding answers is what drives me in my clinical and research practice. In this regard, the profoundly diverse field of rare diseases represents a major healthcare challenge. It has an enormous impact on the well-being of families and has a huge societal cost, and it calls out for an integrated approach. The global importance of this unmet medical need for rare disease patients is recognized by organizations like GA4GH. There are few better examples than the need for data sharing than with rare diseases. And this community with patients, physicians, and their researchers must search for the needle in the haystack to uncover the rare and novel causes of diseases within the genome. But impeding this pace of discovery has been the existence of many siloed small data sets in different institutions, whether they be research or clinical. And just hoping that these data are just sitting in there hoping for a serendipitous occasion when two investigators may meet and discuss that they may have a rare phenotype in common and match these patients to build evidence for causality, for disease causation. As such, the Matchmaker Exchange was launched to provide a robust and systematic approach to rare disease gene discovery through the creation of a federated network of global data sharing. This effort was enabled by the resources and tools of GA4GH and the commitment to data sharing by the rare disease patients themselves, their families, and their clinical care providers. The impact of these efforts is eloquently reflected in the video we will show you shortly. This is the story of Justin and his family who've been followed at my healthcare institution for the past 20 years, since he was just a few months old. Justin was born with a neurological presentation that was undiagnosed and misdiagnosed for more than 2 decades. Recently, we were able to give Justin a diagnosis. He, in fact, has 2 neurological conditions. They are both caused by mutations in genes that have never before been associated with human disease, until the Matchmaker Exchange platform enabled these diagnoses for him. So, from the federation of 40,000 data sets from patients with unsolved rare disease, Justin and his family found 24 patients worldwide with his first condition, and now 3 others worldwide with his second condition. There's already been a family conference for his first condition, and Justin and his family attended this in Texas. And the parents tell us that they experienced a feeling of belonging they've never had before. Justin's father asked me to end this session by saying this to you. I want all the scientists in this room to know that their work is extremely important to people like Justin and to our family. There are so many like us living with a rare disease that has no name. For these families, speed is of the essence. For them, we need you to get this right. Thank you.